Hey guys, welcome to Medifaction. Today, let's learn about obesity. Obesity is associated with an increased risk of multiple health problems, including hypertension, type 2 diabetes, dyslipidemia, obstructive sleep apnea, non-alcoholic fatty liver disease, degenerative joint disease, and some malignancies. Thus, it is important for physicians to identify, evaluate, and treat patients for obesity and associated comorbid conditions. So, obesity is a state of excess adipose tissue mass. Obesity is a disease of caloric imbalance that results from an excess intake of calories that exceeds their consumption by the body. The World Health Organization defines that if a person is having a BMI or body mass index greater than or equal to 25 is considered as overweight, and a person with BMI greater than equal to 30 is obese. In order to calculate BMI, one should divide weight in kilogram with height in meter square. So this is a classification of weight status. In this, a person is considered as underweight if his body mass index is less than 18.5. A person is said to be having a healthy weight if his BMI is in the range of 18.5 to 24.9. A person is considered as overweight if his BMI is in between 25 and 29.9. A person is considered as obese and is categorized in obesity class 1 if his BMI is in the range of 30 to 34.9 and he has a disease risk of high. A person with BMI 35 to 39.9 is considered in the obesity category 2 and he has a very high disease risk. If a person has an BMI of greater than or equal to 40, he is considered as extreme obese and also his disease risk is also extremely high. So, obesity can be due to adipocyte hypertrophy or adipocyte hyperplasia. Causes. The main causes for obesity are lack of energy balance and genes and family history, endocrine causes such as hypothyroidism, Cushing syndrome, and PCOD. Drugs such as corticosteroids, antidepressants, and seizure medications may also lead to obesity. Emotional factors, alcoholism, smoking cessation, pregnancy, lack of sleep, an inactive lifestyle, and also lack of access to healthy foods may lead to get obese. Even though genetic influences play an important role in weight control, but obesity is a disease that depends on the interaction between multiple factors. After all, regardless of genetic makeup, obesity would not occur without intake of food. So this picture depicts that there are many other interconnected factors for one to get obese. That includes psychological factors, neural factors such as vagal afferents, gut peptides like ghrelin, metabolites such as glucose and ketones, hormones like leptin, insulin and cortisol, and other cultural factors. Now let's see how. So, our body consists of an afferent system, a central processing system, and an efferent system. The afferent system mainly has adipocytes which secretes leptin, and also the beta cells of the pancreas secretes insulin, and the stomach secretes ghrelin, and intestine secretes PYY. And these has the capability to give stimulus to the central processing system. The central processing system consists of first order and second order neurons, and from these the efferent neuron system is formed. In efferent, they either stimulate the food intake or the energy expenditure, and both of these will create an energy balance. And also they has the capability of regulating the afferent system. Let's see an example. So, if a person has taken his food, what will happen? His adipose tissue will secrete leptin, and the leptin takes to the first order neuron known as pro-opinionin monocortin or CART, which is the first order neuron. They further acts on the second order neuron, that is melanocyte stimulating hormone, which acts on the melanocortin receptor 3 or 4, and these then stimulates the endocrine system, which results in the release of thyroid releasing hormone and corticotropin releasing hormone, which results in energy consumption. In other hand, we have the intestines and stomach, which secretes the polypeptide Y and ghrelin respectively. And when they are released, they act on the neuropeptide Y, which is an anabolic type, and they act on the Y1/5 receptor, which is the second order neuron, and also they result in the secretion of melanocyte corticotropin hormone or exins, and this causes food intake, and thus the energy balance is maintained. So, as we told earlier, vagal afferent, that is a neuronal control. Vagal afferent are stimulated by the nutrient and stretch receptors from the stomach after food intake. These signals goes to the tractus solitarius nucleus in hindbrain, and accordingly they decreases the feeding, and they causes gastric emptying and increase metabolic rate. Humoral components in detail for controlling appetite. So we know that there are adipocytes, and they secrete hormones such as leptin, adiponectin, cytokines such as TNF, interleukins, chemokine, and steroid hormones. Ghrelin is secreted from the stomach and arcuate nucleus of hypothalamus. Peptide YY is secreted from the ileum and colon. Pancreatic polypeptides, insulin, and amylin is secreted from pancreas. Now let's learn about leptin. Leptin is a 16 kilodalton hormone produced by adipocytes. It is a product of OB gene, and it binds on the OBR receptor, which is a cytokine type 1 receptor family, and they binds to both POMC or pro-opinionin monocortin and NPY or neuropeptide Y, and they result in the increased energy expenditure and not to take food command, and thus they provide signal for energy sufficiency and abundant fat leptin secretion. These can be regulated by insulin stimulated glucose metabolism. Since it is absent in mice, we can find that the mice eats very voraciously. It also stimulates thermogenesis and activity along with energy expenditure. So what if some kind of mutation or any abnormality takes on this pathway? For example, the MC4R, otherwise melanocortin receptor 4. On second order neuron activated by MSH, mutations are more frequent, and this causes 5% massive obesity. There won't be any sensing of satiety signal generated, and the patient behaves as undernourished, and they eat voraciously. Insufficiency of brain-derived neurotrophic factors BDNF, a component of MC4 or downstream signaling in hypothalamus makes obesity in Weger syndrome. Next is adiponectin. These are also known as guardian angel of obesity. They are produced mainly by adipocytes. In obese persons, the levels will be low, and in lean person, the adiponectin level will be more. And they also stimulates fatty acid oxidation. Therefore, it is also called as fat burning molecule. It reduces fatty acid influx in liver and gluconeogenesis from liver. It protects against metabolic syndrome by increasing insulin sensitivity. Adipose tissue. So adipocytes also produce TNF, interleukins, chemokines, and steroids. Why is it important? Because nowadays in COVID cases, we can find that the obese persons are very susceptible to death. Why? Because in COVID, the main cause of death is cytokine storm, which are secreted by the adipocytes. And we all know that the obese persons possess more adipocytes. And this may lead to chronic subclinical or pro-inflammatory state by increasing the C-reactive proteins. So these are acted upon by macrophages, and accordingly macrophages are considered to be regulating adipocyte function. This shows that adipocytes acts are linked between lipid metabolism, nutrition, and inflammation. Gut hormones. Peptide YY, which is secreted by endocrine cells of ileum and colon. Levels of PYY are found reduced in Prader-Willi syndrome. These observations have led to ongoing work to produce PYYs for the treatment of obesity. Amylin. These are secreted along with insulin and pancreatic beta cells, and it reduces food intake and weight gain. Both PYY and amylin act centrally by stimulating the POMC or CART or proopinioid monocortin and inhibiting the NPY, otherwise neuropeptide Y, in the hypothalamus, causing a decrease in food intake. So, why is it hard to maintain the weight loss for those who lose after dietary restriction? It is because on dieting, the adipocytes number never reduces. Adipocyte number are tightly controlled, and loss of fat mass in adult person occurs through shrinkage of existing adipocytes. And since the adipocytes number remain constant, and also adipocyte number is already higher in obese people. Now let's move on to the medical complications of obesity. There will be pulmonary diseases, stroke, non-alcoholic fatty liver diseases, cataracts, diabetes, hypertension, gallbladder diseases, cancers, gout, osteoarthritis, and so on. Now let's see the pathogenesis of complication. As we all know, the main complication of obesity is diabetes mellitus. Around 65% of obese people develop diabetes. The thing is, the obese people has abnormal adipocyte which produces high amount of free fatty acids. And this high amount of free fatty acids results in insulin resistance, which results in hyperinsulinemia. This hyperinsulinemia causes diabetes mellitus and also hypertension. Hypertension is caused by sodium retention. So, the hyperinsulinemia also results in increased growth factor, which results in cell proliferation and finally ends up in cancer. And other reasons or other causes caused by the hyperinsulinemia are increased peripheral aromatase activity, increased estrogen bioavailability, ovarian androgen increase, sex hormone binding globulin production is decreased. So, obesity is associated with insulin resistance and hyperinsulinemia, which are the important feature of type 2 diabetes, and weight loss is associated with improvements in these abnormalities. Excess insulin play a role in the retention of sodium, expansion of blood volume, production of excess norepinephrine, and smooth muscle proliferation that are the hallmarks of hypertension. So, we all know that obesity is an independent risk factor of coronary artery diseases. How? Simple. Obesity causes insulin resistance, which results in higher insulin production, and that causes higher free fatty acids, which causes higher amount of triglyceride and lower amount of HDL. So we can say that it is a predictor of CVS complication. Abnormal obesity associated with atherogenic lipid profile. Excess glucose causes retention of sodium water leading to hypertension. Next, let's learn about syndrome X or metabolic syndrome. This is abdominal obesity. The visceral and intra-abdominal adipocyte deposition can be observed. There will be insulin resistance, hypertriglyceridemia, low serum HDL, high risk of coronary artery diseases, and these are seen more in Indians, probably due to low levels of adiponectin. Next is obesity hypoventilation syndrome, also known as Pickwickian syndrome. In a person with Pickwickian syndrome, apnemic pauses during sleep can be identified. Also, hypersomnolence at both day and night, polycythemia, and also eventually right-sided heart failure will be caused in these people. Obesity and cancer. Both sexes affected equally with high mortality rate. For example, in males, the main cancer-causing organs are esophagus, colon, rectum, pancreas, liver, and prostates. In case of females, the organs involved will be gallbladder, bile duct, breast, endometrium, cervix, and ovaries. So obesity, when it is increased, the synthesis of estrogen from androgen precursors through an effect of adipose tissue aromatases, increases androgen synthesis in ovaries and adrenals, and it enhances estrogen availability by inhibiting the production of sex hormone binding globulin. Management. So the goal is to reduce or prevent comorbidities. There will be diet therapy in case of overweight, and physical activity will also be recommended in case of overweight, and there will be behavioral therapy, and sometimes drugs such as sibutramine and orlistat will be suggested by the physician, and in case of obesity type 3, surgery may be prescribed. Hope you have understood the video. Like, subscribe and press the bell button for more videos. Thank you. Thanks for watching.